So welcome to Ultrarounds for the month of April. I'm going to be presenting on whole body ultrasound. There's been some other kind of terms in regards to this that have been coined by some of the pioneers within critical care ultrasound specifically. That's not what I'm going to be talking about today. We're going to be just talking about what other uses we can use the ultrasound for that actually might be helpful and useful in even in the critical care setting. So I don't really have any disclosure. Oh, sorry, let's actually advance. So I don't really have anything to disclose. But basically this talk is going to focus on what is possible, scanning after hours, and why it might actually be important to be able to do some of these things, especially for our critically ill patients, and maybe even ruling things out that, you know, we don't always have to autopsy everybody. We figured out that the heart wasn't the problem and so on and so forth. I want you guys to notice how many of the scans that are shown in this talk are actually done after hours, because, you know, sometimes patients can't wait. I want to emphasize specifically the democratization of usage of critical care ultrasound, and that even in our hands, we can be as good as radiologists and or cardiologists. And I want to show you that also that if you're using point of care ultrasound specifically to ask a specific question, it is a scalable technology, and it'll put some kind of like examples as to other things within the medical world that are scalable. And it's not that you can't use it just because you're not like a complete expert in it. Finding out even the basic things like, you know, in a PA arrest or asystolic arrest, figuring out whether or not there's tamponade or pericardial effusion even, or, you know, some other basic things is good enough sometimes in those settings to just to rule out, you know, H's and T's and whatever. So just know that don't be like, basically what I'm trying to say is don't be afraid of using the technology just because you can't get it at an expert level. Sometimes even ruling out the basics is enough to tell the family, hey, I looked at this, I looked at that, and so on and so forth. So next up, so Brian and probably all the other kind of POCUS experts have already outlined what the realm of basic critical care echocardiography is. So it's having a look at LV and RV function and size, looking at, sorry, I apologize, the image is maybe not the greatest, but we're having a look at inferior vena cava here, pericardium here, and then just kind of basic valvular stuff. So ruling out massive regurgitation, specifically on the left side, AI and MR. So that's what the CREO's course for, so those of you who have actually attended it will be looking at or have taught you guys the basics on. And to be fair, the large majority of a lot of the diagnoses that we make in critical care ultrasound, even within like, you know, comprehensive echo, 80 to 90% of it can be attained from these basic resuscitative ultrasound kind of pillars, right? Like the things that you're going to be doing and intervening on. And the heavy lifting is going to be based on these 5 things, right? So you need to learn the basics. Otherwise, you can't build up to actually do advanced echo. But one of the things that we get taught along the way is like, oh, do we have to get LVEF, you know, to the exact 5% of 25 versus 30 or whatever? A lot of times, that's not the case in critical care echo, right? Like you're going to be putting on epinephrine, whether it's 20 or 25 or 30 anyways, right? Where those kind of like the distinction between 25 and 30% is going to be things like spironolactone or ICDs and CRT on the ICD pacing and things like that. Those decisions are not going to be necessarily things that you need an exact EF on, right? You guys need to know whether or not it's severely depressed, or, you know, hyperdynamic or normal and things like that, because that'll guide your guys's, you know, inotropes and things like that, titration more so than what the exact EF is, right? And we know within critical care medicine as well, the exact EF, like some patients are completely on room air, not on pressors with an EF of 25%. That's normal. You're gonna, you know, make decisions based on the clinical picture. And then the nice thing about point of care ultrasound is that you are integrating the clinical picture alongside of everything else, right? So that being said, so this was a picture that was taken at the CRS course, I believe in 2018 or 2017, pre-COVID, when we were allowed to meet without masks. And Brett Nelson, who's a colleague of myself and Rob Arnfield's and Brian's, said this about Paul Mayo. So Paul Mayo is the guy on the right, and he's the legendary status to his critical care ultrasound. He's one of the gurus, or basically one of the fathers of critical care ultrasound. And Brett said the secret to Paul Mayo's legendary status is that he wears double glasses. Imagine what he can see that we cannot see. So the reason why Paul Mayo is important is that he actually authored this paper in the ACCP as a statement guidance on competence of critical care ultrasound and the fact that we as critical care physicians are allowed to use it. And I would say that that branches out to internal medicine. It also branches out to anesthesia as well as IM and things like that, that you can learn the basics and even learn the advanced stuff without worry that you're not in an area where you always have to be diagnostic. Sometimes the questions that you're asking specifically are to rule out major things like pericardial effusion, tamponade, and so on and so forth, right? So in Paul Mayo's paper, he actually wrote that basic versus advanced. There's different components and there's different guidelines as to what falls into each category. But a comment that was made at that course from that photo that was just shown is that everybody tries to, like, within medicine, we're all type A personalities. We always try to strive to be advanced, right? So if you can get the basics, you can build on that with more effort. It takes, of the 10, 20% left to learn for the rest of echo, it takes a long time, maybe 6 months, a year, and things like that for those who are in fellowship. But it can be learned. And it's fairly rewarding, especially if you're able to get a lot of these diagnoses under your hat, right? So so Paul Mayo basically said at that course that nobody wants to be basic. Imagine, BLS ambulance versus an ACLS ambulance. I think the ACLS guys probably, jab the BLS guys in being able to do, like advanced things and thrombolysis and so on and so forth. So I would say the same thing within critical care echo, that if you want to learn it, it's achievable and that it's highly rewarding to be able to do these things. So hemodynamics, device placement. So this one, I believe, is a intra-aortic balloon pump. You can guide VV ECMO. Aorta assessments, so looking for massive aneurysms or dissections and so on and so forth. Ruling out endocarditis and cardiac sources of embolism is not. So this is not a comprehensive list of what can be done with critical care training and advanced echo training or advanced kind of ultrasound training, but it's just like a smattering of things that you can do. This was another year back in 2015 when this the CRS course in London was running, and basically there was a paper that came out from Volpicetti et al. He's the one of the Italian gurus in ultrasound, and basically he identified that in 5 minutes you can take an undifferentiated patient in hypotension and basically work them up with basic cardiac, basic thoracic, DVT, and limited abdominal scans. And he basically coined it as a term called WUBU, or just whole body ultrasound. And that is a quick and dirty way. It's like even faster than the FAST exam to be, not faster, but like it's as comprehensive and even more comprehensive than the FAST exam and maybe just as quick to be able to work up an undifferentiated shocky patient. There's been other kind of things from Andre Denault over in Montreal. I'm not sure if Jean's on the line, but HOBUS, or whole body ultrasound for ICU and OR patients and anesthesia in 2019. That also came out in the Critical Ultrasound Journal. So there's things that you can learn, not just the echo and not just the lung stuff, but you can add on DVT and some other things to be able to work up patients in shock. So that's not the point of my talk today. My talk is going to be on other applications that you can use even within the critical care setting. So when you go into, this is a power chart, which is a computer system within in London. Basically, you can type in ultrasound and you get all these different things that the radiologists and even cardiologists might be able to do. So there's lots of different orders, lots of different things you can scan. And so are these things that could be in the armamentarium of a critical care physician? Potentially. They all require, more training or practice on these things. And there's also guidelines on how to basically train people up in these different areas, but they are achievable. So again, you can do head and retinal scans, looking at TCDs. You can look at the carotids, DVT, thyroid, airway, biliary, and the abdomen stuff. So biliary, liver, spleen, kidney, bowel, free fluid, aorta, OB-GYN stuff, which we'll show some cases on. Like all these ones, we'll try to show some cases on, and testicular, thorax, so lung, heart, aorta, and breast, and then DVT, peripheral nerve blocks for some of the anesthesiologists in the crowd, and skin and soft tissue and MSK. So the ultrasound is like a Swiss Army knife, and with a Swiss Army knife, you can have different features within each of the different types. I want to liken this to bronchoscopy, for example. So we can do BALs in the critical care setting, but it takes advanced training to be able to do EBUS or transbronchial biopsies and so on and so forth. So again, it's a scalable technology, and whatever you want to learn to be able to be confident in what you want to be able to diagnose, you can do. And the same things for like EKG, right? So an EKG, you can have a 12 lead, 15 lead, push gear leads, all this other stuff, right side leads and things like that. But we train even medical students all the way up to the expertise with an EP specialist, right? But we don't say, oh, the medical students aren't allowed to use EKG, or like critical care physicians are not allowed to use ultrasound. Not allowed to do bronchoscopy just because you can't do EBUS or you can't do the more advanced stuff that EP specialists would look at in the EKG. So why would we do that necessarily for ultrasound? If we can at least train everybody on the basics, and then whoever wants to learn the advanced stuff and get up to that level and write that exam and do that fellowship, why don't we let that happen? I think it's more of a political thing, and it's more than it is a training thing. And I think that people can be trained in this way. So, myself and Brian and a lot of the people within point of care ultrasound, we want to democratize the use, because the more people that speak the same language, be able to have the skill set and be able to diagnose things, the better patient care that we can provide. That way you're not waiting till Monday, 8 a.m. when cardiology can come by or radiology can come by to do your scan. You can still look after patients on Friday night, Saturday morning, early in the morning and things like that. So the same way that ultrasound machines are starting to become ubiquitous in the emergency department, ICUs, on the floors and things like that. Nobody owns laryngoscopes, nobody owns bronchoscopies, nobody owns EKGs. Everybody can use them. You just have to get trained in it. So that's what I would say about that. So ultrasound is also one of those things that leads to from diagnosis and moves the needle closer to prevent potential intervention. And it's a disruptive technology, right? So especially in the hands of new users and things like that. So, critical care using it more, emerge using it more, IM and anesthesia. It's a disruptive technology, but it's in a good way, because you can make a diagnosis and actually get intervention for that patient. Because the thing is, like, you can diagnose something, but you might not be able to intervene on them unless you can kind of convince the other person on the other side of the phone that you have a scan that shows the thing that it's supposed to show. So I'll give you an example of a case. So crescendo, decrescendo murmur in the second intercostal space with brachial rate of delay in keeping with severe AS. But no surgeon is going to operate on them or work them up or get them into their clinic for aortic valve replacement unless you have the echo, right? So if you have the echo and you have the images, you might be able to actually convince somebody to actually do something about it. So for example, we had a 50-year-old guy with a type A aortic dissection, CT chest that was done in the periphery, definitely showed the type A, but it was only in the ascending aorta only. And it was transferred from that peripheral site to the CV ICU where I started looking after him. The CV resident basically auscultates the chest and says that, hey, they actually hear a diastolic murmur. And again, this flap on the CT hadn't shown that it had gone to the aortic valve yet, but there's obviously a change within clinical findings. And the patient had muffled heart sound. So I basically came over after the resident had assessed the patient. And the POCUS TTE already showed severe AI, moderate pericardial effusion. So the surgical plan for that patient was actually, well, get them on labetalol, treat them medically, and we'll operate on tomorrow. Actually, the POCUS was able to convince the surgeon to operate that night and actually call in the aortic specialist from CV, right? And they added an arch replacement and a Bental. So it actually changed management in the moment, right? So it wasn't like, oh, we just went on the CT findings. The POCUS actually changed management and actually got that patient operated on earlier and actually changed the operative plan. So it was important to actually do it. So we'll actually get to some images and some cases. So hopefully they'll play. I apologize if they don't. So basically, you guys have seen this before, probably some live images. So this is a pleural effusion. There's some arrows that are kind of showing the diaphragm, chest wall, pleural effusion in the lung. We know that with some certain skills, you're able to measure from the inferior edge, the superior margin of the diaphragm to the inferior edge of the lung. And if we multiply that number, so 7.6 centimeters multiplied by 200 cc's per centimeter, we can actually estimate the size of a pleural effusion. So that, again, primarily what I'm showing you what is possible. You're going to require, like reading textbooks and training and doing fellowships and doing your own scans to be able to learn these skills. But I'm just trying to show you guys what, in terms of cases and images, what is possible. So next one is an example of plankton sign. So again, like we have a pleural effusion here. But what might actually change your management is finding this plankton sign because it shows complexity within the pleural effusion. And so instead of maybe like a thoracentesis or just doing like a pigtail drain, in the right context, you actually might need a surgical drain for this, and you might have to instill TPA and things like that. So finding these findings within lung ultrasound is important, right? So next up is an example of dynamic and static air bronchograms. So these are important as well when you have a look at the lung ultrasound. So this, dynamic air bronchograms basically show that there's air and pus and fluid moving within the airways. And so the differential diagnosis for a consolidated lung like this, where it looks like this, is either atelectasis or it's actual infection or pneumonia, right? So the dynamic air bronchograms help you actually rule in a actual infection and that this is not atelectasis, because otherwise you wouldn't see air and pus moving. If it was an atelectatic lung, it would just look dense, but you wouldn't see anything in the airways, right? Because atelectasis by definition is collapse of those airways, right? So helps you, other things that you clinically correlate with white count and sputum production, things like that. Dynamic air bronchograms also helps with that. And so that example actually led to a bronch for this patient, right? So instead of just us, recruiting the patient with high peaks and things like that, and the chest X-ray basically showed a whiteout of the lung, this was the reason for that. So it actually led to intervention that led to this. Because the first thing that was going to be done is that for that other patient is that there was a pleural effusion there for sure, right? Like as you can see from the previous image. So the first thing that we were going to do for that patient was actually tap the chest. But actually this led to saying like, well, the pleural effusion wasn't as large and maybe moderate in size. Maybe there's something else going on and there's a dynamic air bronchograms. So that patient actually had hypoxic respiratory failure, most likely from a plug than it was. Like the effusion got drained later, but we actually changed our plan in terms of managing the patient by finding the plug first, right? So we can do advanced echo as well. So as you can see here, this is a poorly, poor EF patient, and we have the calcified aortic valve. We can do valvular assessments and actually assess for AS in these patients. So if we do a good apical 4-chamber, 5-chamber view, we can actually do peak and mean gradients to actually diagnose, aortic stenosis. We wouldn't use just aortic stenosis gradients in this patient with a poor EF, because usually you'd have to have EFs greater than 40% to actually trust the gradients. So in this patient, we actually ended up using the continuity equation or the dimensionless index to be able to diagnose a patient with severe ES. So this patient definitely had severe ES. I'm not sure why it's not advancing to the next stuff. I'll just maybe show it here. Oh yeah, here it is. So basically this is the same patient. We're doing aortic 5-chamber view, and we're basically doing a continuous wave through this through the aortic valve. And you'll notice that the peak gradient, the mean gradient here is only 34. So by mean gradient criteria, we'd only call it moderate stenosis, right? But we know the EF is poor, so they can't mount a good gradient against that aortic valve. So actually this is an underestimated, this is low output, high grade severe AS still. So we actually don't use that, and we use other things. So we can use the continuity equation, but we can also use the dimensionless index. So you'll notice that the peak gradient here, or velocity, is about 4 meters per second right here. And then I might not, actually I don't have that slide here, but basically when we did the pulse wave right in front of the aortic valve, so just the LVOT gradients and the velocity there was only 100 centimeters per second. So the fact that it got 4 times faster from the LVOT through the aortic valve, using a dimensionless index, we can actually diagnose severe AS just based on that, not even having to do the continuity equation. So it's important to have these skills, and it's not really like, for a lot of the people who are online who are doing the fellowship right now, it doesn't take that much extra work. Remember, it's a 10 to 20% to learn these other things, but the actual like acquisition and being able to interpret these things, it's not that much harder to learn. So like, and it might change your management for this patient. So for example, we definitely changed our anesthetic management when she was in heart failure and things like that. We stayed away from propofol. We stayed away from the other things. We tried to minimize her sedation to try to make sure we didn't cause her to crash when we intubated her, right? So we can also look at our RVSP, pulmonary hypertension, TAP-C for RV function. So again, like very easy things to actually acquire. And then you can memorizing all the cutoffs and things like that is not always necessary. You can look them up, like just know how to be able to acquire them, and then be able to look up the cutoffs and things like that for other things. Some of the more advanced stuff that will come up on the critical care echo exam for the people who are online who are planning to write it. Diastolic dysfunction, it's not really a sexy thing within critical care because, we usually find LV function or, left-sided valvular disease as a cause for it. But if it's, all those things are ruled out and it doesn't look like that's part of the presentation, but the patient's still in heart failure and they have a dilated IVC or whatever with no respiratory variation, you can do diastolic dysfunction assessments. And again, not like it's about 3 or 4 extra images you have to capture to gain, pretty good information to be able to diagnose some of these things. And, the treatment for it is, fairly simple compared to like everything else. We diurese patients, we beta block them, afterload reduce them and things like that. So, but at least you'll have a reason as to why you're doing those kind of things, right? So, some of the more advanced things that you might be able to find is like endocarditis. So this is a transesophageal echo in the mid-esophageal long axis view. And you can see here that if we put color on it eventually, I'm not sure whether or not this clip will show it, but in the right context, in the right patient, these can be like decided on very quickly. Next thing up is cardiac sources of embolism. So, in some of the stroke patients that end up in the ICU, since they're already intubated, sometimes we can put down a TE probe. This is a mid-esophageal long axis view at 90 degrees. And basically what we're looking at is the left atrial appendage, which is seen here. And as you can notice here, even to, patients, people who aren't trained, you'll notice that there's some cloudiness that's spontaneous echo contrast. And you'll note that, is this just an issue with gain? It's not an issue with gain because you can tell the LV itself doesn't have the same cloudiness, right? And, in the right context, in the right patient with a CT scan or MRI that already showed stroke, this might be something where, like we're not allowed to anticoagulate those patients with IV heparin, even though we know they were in AFib, or maybe they weren't in AFib and we don't know this and we find this as a unique finding. But we have to hold off anticoagulation for some time just to make sure that they don't have hemorrhagic transformation. But this might be a prognostic sign to say, hey, like this patient might actually do worse overall, and that waiting for, anticoagulation might not be an option for them necessarily. Or if they stroke again, you'll know why, right? Because they had a big clot in their left atrium, right? So next up is some examples of this one is a shunt on the left-hand side. So this was a patient who was on previously nitric oxide and low PEEPs, and clearly had, they came in for respiratory failure in NYD, so that like we weren't even looking necessarily for a finding of this, but we want to explain why they were so hypoxemic, and then also when APRV and higher pressures and things like that were not working, why was that the case? So basically we found the reason, right? So we did a bubble study. You can see shunting across, either a PFO or an ASD on this patient. And it's quite robust within 1 to 2 cardiac cycles. So again, things that you guys can learn fairly simply. And the bubble study is not difficult. We're doing it as part of our research stuff. And for some of the fellows and the trainees who've been online, it's a useful tool to be able to get. Even if you just get a 4-chamber from subcostal or for apical 4, and you do the bubble study, you can at least quickly rule in whether or not there's a right to left shunt. You might not be able to pick up whether or not it's a PFO ASD necessarily, depends on your training, but at least you'll be able to figure out whether or not the, a shunt is a cause of some of the hypoxia. Next up is, so this was a 80-year-old, 90-year-old patient, and you'll notice that it was done at 10 in the evening. And basically this is a TE, she was already arrested and intubated, and basically they put the probe down, and you'll see the color that's kind of going there. You'll see this dissection flap coming from the aortic root, and it's not running there. And this is the descending thoracic aorta. They put color across, and you can see one lumen is lighting up very nicely with color, and the other lumen is not, right? So this is a dissection flap. She was resuscitated and actually eventually extubated. And we were seeing her in the emergency department basically. And we actually told her and she had bad kidneys, so we didn't really want to send her to the CT scan, and she was 89 years old. And we said, look, we actually have a diagnosis of dissection for you. Do you want to be referred on to the surgeon? She's like, nope, I lived a good life. I'm happy. Just treat me medically and things like that. She eventually did pass away, but it saved a lot of the other stuff that needed to be done, like the CT, just to prove it. We could have knocked out her kidneys and things like that. She lived for maybe another week or 2 in hospital on the medicine floor, and she just got good pain management and good hypertensive control. But she eventually did pass away because she continued to dissect. But at least we didn't, have to do a CT wasted and give her contrast and things like that and cause her to go into renal failure faster and so on and so forth. So, all right. Next up, so vascular DVT is something that you guys can learn. So again, lower extremity DVT is probably one of the mainstays of workup, specifically in whole body ultrasound, especially in the right patients. So there's 4 stations basically you need to check in every patient. So 4 up in the femoral region and 1 in the public. So the stations are basically common femoral vein coming down from the iliacs, and then you have the bifurcation of the greater saphenous vein. Then you'll have the bilateral perforators when the aorta splits and you have the Mickey Mouse sign. And then in addition to that, you'll have the deep and superficial femoral veins as well. So that's the 4 station of the femoral, and then you have a popliteal. You guys might have heard this either at the course or through teachings that POP is on top. So when you basically insinate the back of the person's knee, look for Baker's cyst and things like that. But if you see a vein that's collapsible on top of the artery, that's the POP on top sign. And basically, if it's compressible, it means that there's no clot basically in that lumen. You'll notice on the image here, though, that this patient that's playing, so this patient actually has a femoral line in. And unfortunately, we shouldn't be compressing too hard if there's actually clot there. So if you actually see a clot there, document it and don't do the compression necessary. Don't milk the clot up into the chest, right? Don't cause a PE. But basically, if you can see something there, don't compress. If you can't see something there, go ahead and compress. And if it doesn't fully compress, it might be an early clot and you might not be able to just see it echographically, but the fact that the walls don't come together is already a worrisome sign. So again, if you compress lightly, don't milk the clot up into the chest and things like that. Make sure they have good anticoagulation. And if any of these signs are actually found while the patient is actually in peri-arrest or things like that. So I think Brian has a really good case of when he was in London, there was a patient who was in the CT scanner and he scanned the back of the leg with popliteal and the patient was arrested and he basically made the diagnosis. So the patient was being sent down for a CT scan of the chest for PE and he ended up thrombolizing the patient. I think the patient survived, right? So like Brian can tell you all about that story, but like that's one of the classic things that we can do at the bedside. So so this is upper extremity cephalic brachial and axillary as well. So you can also see that there's echogenicity and clot basically forming within those vessels as well. So again, upper extremity DVT is also a possibility for you guys to learn. Abdominal aorta. So you can see here, so this is the abdominal aorta here. Abdominal aortas are not supposed to be greater than 3 centimeters from measurement. And we basically go from the leading edge to the leading edge, not the outer edge to the outer edge. And for this patient, not only do they have an aneurysm that's greater than 3 centimeters, it was 9.34, you'll notice that the patient also has a type B dissection here as well that's highly calcified. So this was a long-standing kind of issue. And then if the patient bleeds as well, you can look outside the aorta to see whether or not there's hematoma. This is not always well seen because remember the aorta itself is a retroperitoneal structure. And so you have to have a good trained eye to be able to find that hematoma around the aorta, ruptured aorta. And remember, it's not going to necessarily spill into free fluid in the abdomen because it's a retroperitoneal structure. You're not going to see free fluid in the abdomen. You have to kind of train your eye to see whether or not there's a hematoma on the outside, but it can be done, right? Next up is biliary. So I think so these are liver mets here. Some of the other clips are going to show that basically there's a gallbladder. You can see some gallstones sometimes in there. If you're worried about acute cholecystitis, remember there's 4 findings. Gallbladder thickness greater than 3 millimeters. It can be falsely elevated if the patient has ascites or things like that because the gallbladder edema itself, the walls can get thick on its own. But if you see sludge and stones in the gallbladder, if you see a sonographic Murphy sign, so again, all these things are things that we learn about, in medical school. And you'll see here that there's stones here and there's that shadow effect. So you know that they are stones because they're calcified and you have that dropout, just like if it was a rib in the chest, you see that dropout effect of seeing something calcified there. And last but not least, if you see pericholecystic fluid, that's another sign of acute cholecystitis. You only need 2 out of the 4 criteria to even get, like mild suspicion of that diagnosis. And you have 4 out of 4. You're pretty much, on your way to diagnosing that. Like you might still need, liver enzymes and things like that. But if they have right upper quadrant pain, you could be able to diagnose this on your own. So this is just a measurement basically of the point. It's not quite 0.6 centimeters, but if, greater than 3 millimeters for this is the cutoff for a thickened gallbladder. So this is the thickened gallbladder wall, basically, right? Next up is that we can have a look at hepatic veins. So I know that Brian's been trying to bring online the VEXUS studies a little bit more, and I think he's also doing the ECHO-AKI study with William over in Toronto and Montreal, and Ron Wald. So pulsing hepatic veins. So again, you have your left, middle, and right hepatic veins. They're contiguous with the IVC, so you can see the IVC here. They're non-echogenic walls, so you can tell this is different than what I'm going to show you next. That's the portal vein. So the portal vein has echogenic walls, and it's from the collagenous tissue that's around the hepatic vein. But we can pulse all these things to be able to find and see whether or not patients actually have, either continuous flow. So I'll just go back here. You'll notice for this particular hepatic vein. So hepatic veins have a little bit of different flow. So normals here, you have a big systolic wave underneath the baseline and the diastolic, and then you have your atrial kick. When you get into severe congestion, you have a small reverse systolic wave, still a big diastolic compared to previous, and you still have that atrial kick. In the in the portal vein, you'll actually have continuous Doppler, basically, when the patient's not volume overloaded. And once you start getting volume overloaded, or you have, venous congestion in the liver or in the organ itself, you'll start getting some pulsatile flow, and you might even get some to and from flow, basically, right? So all these things can be done in the right patient, in the right patient population. So some of the other stuff that we can learn is, this is severe hydronephrosis. So you can see here, this is the kidney. Normally the renal calyces and things like that are very small, and this is all just full of urine, and it's basically destroyed the renal parenchyma as well. So there's different, grading systems. So this is severe hydronephrosis. You have the bear claw sign with moderate hydronephrosis. And then you'll just have dilation of the calyces, basically mild hydronephrosis. You can diagnose stones and things like that if you find echogenicity. It's just like diagnosing gallstones. You just have to find it in the ureter and the calyces themselves. And then you can also, this is classic for a lot of the people who do fast exams in the emergency department, just looking for free fluid. This is a lot of free fluid, but we can actually use it for procedural guidance. So you'll see there's a wire here, basically coming down, maybe not in this image, but maybe in some of the other images if it'll play. But basically, you can help do it with your procedural guidance for your paracenteses, and you can measure down how many centimeters before your needle is going to hit bowel, right? So then you can, landmark and also safely do procedural guidance during these things. So these are all things that are possible within your own hands if you choose to learn it. Renal congestion, we'll talk about very briefly. You can pulse basically the vein and the arteries here. If there's a transplanted kidney, you can look for resistive indices and so on and so forth to see whether or not they're high and whether or not the kidney itself has good flow. So again, things that can be done, and I believe Brian's doing a lot more of this within the VEXUS world as well as within ECHO-AKI. So yeah, things like that. So again, this is kind of the VEXUS teaching in regards to like the renal parenchyma and the renal artery can be pulsed and found out. The liver has the hepatic veins and the portal veins that can be pulsed. You can have your IVC as well, and then diastolic dysfunction as well for right atrium. And so this is a Tang et al. In the Jack Heart Failure 2016. So these were the echocardiographers in the cardiology world that were also looking at kidney, liver, and IVC to see whether or not patients are volume overloaded. So again, advanced skills. Once you learn Doppler in one area, it's pretty transferable to a lot of other things. And all you have to really do is be able to memorize some of the cutoffs. Or if you can't memorize them, that's okay. You can measure it and acquire it, and then just go get a textbook later and be able to look up the cutoffs for all these different things, right? So again, you don't have to necessarily rely on being able to measure the cutoffs in the moment. You can learn to acquire it first, and then learn the cutoffs over time and things like that. So we can have a look at bowel as well. So again, classic way that we diagnose bowel obstruction is actually with plain films or CT abdo and things like that. But we can see this to and fro motion of peristalsis. Intra-abdominal fluids called a Tanga sign in the right patients for bowel obstruction. And then if the bowels are dilated greater than 2.5 centimeters, you can measure them across like that and then see whether or not they have wall thickening. I've never diagnosed pneumatosis before myself, But some of my emerged colleagues have said that they found actually like gas and stuff in the walls, and so they diagnosed pneumatosis as well. Hopefully a CT or X-ray would also be able to show. So this might be more academic than anything, but it can be done. For all those who are interested in general surgery, so this is the appendix here. It's right over top of the iliac vessels. So generally, remember you're not always going to find the appendix in this orientation right above the iliac vessels. They might, it might be retrocecal. So again, not all the appendices are going to be found this way, but if you were worried about it, you could theoretically look for it. And then the other thing about that particular, so this one at the start here, you'll notice that the walls of the appendix are not thickened. And so the cutoff for here is about 0.6 centimeters. And you'll see on the second image, sorry, it's playing a little bit fast, but you'll notice that this one is a little bit thicker and is a little bit more inflamed as compared to the previous one, right? So, and there's ways to actually measure out the wall thickness. And so for this one was 0.46 in cross section, but the wall thickness itself was actually 0.7. So it was abnormal, greater than 6 millimeters. So it actually led to, and this was, I believe, in a pediatric patient. So again, another reason why to not necessarily CT somebody who's like 10 years old. It's a nice skill to have in the hands of the right clinician to be able to diagnose this. So next thing up is OB-GYN cases. So these are some of the ones from the Victoria Hospital in London, Ontario. So we were able to diagnose actually, intrauterine pregnancy. And a patient, like this was at 4 in the morning. And again, the concern was abdominal pain. She had some, vaginal bleeding. And you can diagnose things like fetal pull, decidual reaction, yolk sac, ectopics, and fibroids, and a live intrauterine pregnancy as well. And also molar pregnancies is something that you can learn. The next clip up that I just wanted to show. So that was a live uterine pregnancy in a patient with positive beta HCG. And then this is a much more, advanced in terms of, this, I think this lady was unfortunately 30 weeks along, and she has spontaneous coronary dissection. And she actually ended up having intrauterine pregnancy and a late uterine pregnancy at 30 weeks. And initially she presented on the weekend. So again, we weren't able to get necessarily an ultrasound of her. So we did an ultrasound to see whether or not her fetus was still alive. So you see here that we did a M mode through the heart here. So you can see the fetal heart kind of beating away on the side. And we basically put an M mode through there and be able to calculate, we see all these fluctuations up and down. And using a caliper, we were able to measure that her baby's heart rate was 150 beats per minute. So it was actually normal at the time, because we thought maybe if she arrested is her baby in distress. And we thought that this was a good way to manage this because the OB hadn't come yet. They were busy with another C-section. So we were able to diagnose this right off the bat. Unfortunately, because the patient got hemodynamically unstable, the fetus got hemodynamically unstable. So we kept doing this serially, even though she had a tokodynamometer on. And eventually, unfortunately, we saw what we call the barcode sign. And the barcode sign was that the fetal heart was not moving at all. And then we did this again with an M mode through the heart. And it just basically showed a barcode. So you didn't see any of these fluctuations in the heart. So the patient and the fetus eventually passed away, unfortunately. So that was a sad case. But it's something that you can do in the throes. I'm not sure if our colleagues over at the Royal Alex see a lot of pregnant patients. Maybe they might see some more as the pandemic goes along, but ways to be able to monitor even the baby. Does it mean that you have to figure out the crown rump length and all this stuff? No, you're there as a resuscitation. So you're using it for point of care, questions and things like that. You're just trying to figure out whether or not, has the baby died and things like that. So, yeah. The reason why we don't use pulse wave necessarily to actually go through this is that we don't know what ultrasound waves actually do to the heart when we pulse it specifically. So when we do a general fan of the patient, that is actually at lower frequencies. When we actually do a pulse, it's at higher frequencies and it can theoretically cause harm. So we use the Alera principle as low as reasonably allowed. So that's why we use M mode across the heart. Do not do pulse wave to the heart because we don't actually know what it can potentially do to the fetal heart rate. So that's why a lot of the investigations that are done for the fetal heart are done with M mode. Ocular stuff. So, Brian's done a lot of teaching on optic nerve sheath diameter. So that's one thing. Another thing that some of the emerge docs like to do is that, MAC on or MAC off. they'll put some ultrasound gel on the probe and they'll, scan the eye and they'll find, a retinal detachment. So like there's ways to do this. And again, a lot of these are done in the middle of the night when maybe you can't get access to your, ophthalmology colleagues necessarily because they're either, away or doing other stuff. Some of the other stuff that we can do is airways. This is not necessarily the best image, I apologize, which is why it's so heavily annotated. But we can actually see the cricoid cartilage. We can see the air mucus interface. You can see the rings, one ring here, and then the thyroid isthmus we want to avoid. So again, if you have your bronch, but if you want to help landmark for, not you do it for our colleagues here necessarily in ICU, but if they wanted to know, where the cricoid cartilage was in the first and second ring, you could, theoretically find that for them. And then soft tissue edema. So you'll see a lot of cobblestoning here. So a lot of patients that are very volume overloaded might have this finding. So this is not necessarily just the thing that we're looking for, but a lot of patients get that kind of differential diagnosis. Is this, cellulitis versus neck fascia, right? So there's actually ways for you to be able to diagnose neck fascia. So here's some cases. So you'll notice that the fascia here is intact. But as the clip plays, hopefully it's not too choppy on your guys' end, it's choppy on my end. But you'll start seeing A lines. So A lines are things that you normally find in the lung, right? So if you see A lines, emanating down within the fascial planes and things like that, and these kind of bright marks, and you see A lines. That's not normal, right? So you might want to get, an X-ray or a CT and look for that gas and things like that. So, it might not just be that cellulitis, it actually might be neck fascia. And there's ways to actually kind of help rule that in. It's going to be hard to rule out with ultrasound, but maybe something that rule in, and a lot of point of care ultrasound is like that. So this was in a peds patient. What ended up happening was, I think the techs were really busy with a whole bunch of other stuff. And so the emerge doc said, like, hey, it's, a pediatric patient and we're backed up here. Why don't I just put the ultrasound on? So you can diagnose, fractures as well. You can see here, and it was done at, like 11:30 at night. And they eventually obviously did the proper things by getting the x-rays, getting it casted and, getting it set and things like that, giving sedation. But again, just to kind of quickly diagnose what was happening, they ended up putting the ultrasound probe on. So joint effusions as well. You can see here that this is the patella, this is the femur, and you can actually, most of the time if you're tapping a knee, it's going to be done blind. But if you ever really wanted to know whether or not there was an effusion there to tap in the first place, you can, be able to find the synovial fluid, find the synovial pocket and be able to tap that. You could theoretically use ultrasound to do that as well. TCD is definitely coming a little bit more in vogue. And what you'll see here is that, so you see the cerebral peduncles or the bilateral thalami are usually heart-shaped in nature. And then anterior to that should be your circle of Willis. So again, ACAs should be heading in this direction. There would be ACOM between there. The terminal ICA comes up out of your screen. So it comes out of your page here. And then it ends up as being part of the MCA. Again, the MCA is not technically part of the circle of Willis, but it, it comes up basically from the terminal ICA. And you can have that on bilateral sides. And then as you go further back here, you have the PCAs back here, and then the PCOM will connect that. Not everybody will have an intact circle of Willis, as the neuro colleagues can attest to, but you can, be able to use the MCA for a lot of different useful interventions and investigations. So you can diagnose vasospasm, greater than 200 centimeters per second for a mean gradient is abnormal. So that's severe vasospasm. Between 120 and 160. 120 and 160 is mild, greater than 160 to 200 is moderate, and greater than 200, as I mentioned before, is severe. You can use it to diagnose things like brain death. So I think Jim Koutsoulianis talked about this in terms of, so back in the day, even within North America, back when I trained back in London, TCD was not being used, especially in Ontario, to diagnose brain death. It was primarily used in Europe and in South America because they don't always have access to nuclear medicine scans or CTAs, MRIs, and things like that. But the whole idea is that you diagnose cerebral circulatory arrest and you can have raising an ICP. So the way that this kind of goes, so this is called the Hassler diagram, and it's based on, a neuro sonologist from Austria. And basically, the MCA that's being used here is very similar to like an art line tracing. So you'll notice that when ICP is low, so decrease CPP, so therefore increase ICP as you go along these lines. that it looks like a normal art-line waveform. And eventually, as the vessel gets compressed a little bit more from the outside, you'll notice that it's just like putting your finger over top of a garden hose, right? Like the smaller diameter. So you have more compression from the outside. So therefore, the systolic velocities get a little bit faster. And because ICP is competing now against diastolic pressure goes down, right? So you have this basically increase of the what's called the SD ratio, or the difference between systolic pressure and the diastolic pressure. So we can actually use that and calculate an ICP from this thing called the Seidler equation, and basically convert a what's called the pulsatility index into an ICP. So as you can see here, as this gets even higher, diastole gets even lower. You can have diastolic blunting to the point where it's completely gone. And then when ICP outcompetes diastolic flow, you can actually get diastolic flow reversal. So this is where cerebral circulatory arrest occurs. You'll notice that the flow within going forward, so you can imagine these are little red blood cells going forward and backwards, right? So it's going equally forward and equally backward, equally forward. And this one's even more obvious that the peak here and the peak here are exactly the same. So a red cell that's going this way, this way, this way, this way, and staying in the same spot, not going back to the lungs, is going to get deoxygenated. You're going to have anoxic brain injury. And so that's by definition cerebral circulatory arrest. Even though there's flow in each direction, it's equal in each direction, right? So that's one way to diagnose cerebral circulatory arrest. The second way is actually this thing called systolic spike waves. So you notice that this cutoff here is 100. If they're not reaching at least 50 centimeters per second, that's actually really important. That cutoff is really important because when you put that into the modified Bernoulli's equation, it becomes 50 centimeters per second becomes 0.5 meters per second, right? If you square that, it becomes 0.25. 4v squared, 4 times a quarter equals 1. So that's why that 50 centimeter per second cutoff is so important, because that equals 1 millimeter of mercury pressure. Nobody can survive with a brain pressure of only 1 millimeter mercury. So that's why even if you have flows like this, you can diagnose cerebral circulatory arrest because it's imminent, basically, because you're not providing pressure. Where you actually have loss of flow, it's the same thing that Jim said on his Grand Rounds talk. It's actually a little bit more difficult to diagnose because you have to have proven that they had flow beforehand and then they lost it. And then you also have to prove extracranial flow. So what you do is you basically scan their carotid. So if they have carotid flow and then you're scanning, and half an hour earlier they did have flow and then they lost it and you can't find that MCE flow, you drop your Nyquist down below maybe 15, 10 or something like that, and you still can't find flow, it's likely that they had a cerebral circulatory arrest. Sometimes where I use this is, again, within North America, I wasn't necessarily keen on saying like, oh, for sure. Like, I mean, these are very, suggestive of it. If you have basically biphasic flow or, oscillating flow, or you have systolic spike waves, very in keeping with cerebral circulatory arrest. If you lose flow, my suggestion would probably be like, especially in the right patient who's like, phenobarb coma, things like that, and you're just not finding it. It might actually trigger you to do one of the confirmatory tests with a nuclear brain scan or a CTA, MRA, or like invasive angiography. Not that we do that regularly anymore. And sometimes what ends up happening is if you see flows like this, like it might be heading that direction, but they're not brain dead yet. It might save you from actually doing a scan too early, right? So if you haven't seen that they've actually, despite the fact that they're clinically maybe, like arrested and things like that, and they're not triggering the event, their, brainstem reflexes are all gone. You might be able to actually diagnose this and then be able to send the scan with more definitive kind of, certainty. And that way you don't waste it, because I remember Jim had mentioned, and I know Dustin has mentioned this to me before, that sometimes when you waste that nuclear medicine scan on a patient that has a little bit of trickle flow or CTA, then you can't do it for another 48 hours, right? So this might be a way to be able to time that a little bit better, especially in the right patient who has some sort of other confounder or some sort of just distracting injury and trauma, or some sort of overdose of some sort that has a long half-life and things like that. You might be able to diagnose it a little bit better. Carotid scans. So, I mean, we look at carotids all the time. We just never really do anything about it because we cannulate the IJs whenever we're doing that. But you can actually do flows and stuff like that in the carotids. And the important thing about the carotids is sometimes, so this was a patient who had a carotid stent. And what you'll notice here is that the stent has something opacifying it, and that's not normal, and that's not supposed to be there. And actually what we did is, I believe later on, we put color flow. So again, should have been in this direction, red color flow, but the flow at the end of that clip was actually retrograde. So it was coming actually from the circulus down towards the cross. So the patient had actually had a stroke, had a stent, re-occluded that stent, and we were actually able to diagnose this even before the CT kind of confirmed it. The patient didn't do well overall, but we were just able to kind of figure that out and just saw that the flow was actually retrograde rather than antegrade, and there was no flow. You'll notice actually within the stent itself because it was completely occluded with clot. So we can also diagnose carotid stenosis, and there are guidelines from NASCEP to actually be able to diagnose this. So again, a lot of these guidelines are out there in the POCUS world. We're not here to recreate the wheel. We're just kind of learning the skills. So a lot of the skills that I learned and maybe Brian learned, especially these ones that are not necessarily within the POCUS purview, we just ended up sitting with techs, or we talked to radiologists who were willing to train us. And we were able to learn a lot of these skills along the way. And again, a lot of these cutoffs and things like that, you can look them up, right? Just you have to have the skills to be able to scan for it, and then be able to, diagnose the thing later. And you can sit on your computer on QPath, take all the time you need, look up whatever resources you need to be able to do to make your final diagnosis, right? So one thing that's really important, and again, so this was a clinic patient actually I saw while I was in London. It was in CV surgery, and the patient was, on high oxygen in the clinic, like 15 liters. He's on home O2 anyways, but basically he wasn't a COPD exacerbation. He was basically an effusion. So what I ended up doing is I actually ended up, diagnosing they had a 2-liter effusion on that side, and I actually ended up tapping him in the clinic. Right, so he actually avoided an admission to hospital just because we were able to tap the thing while he was there. We were worried about re-expansion pulmonary edema and all these other things, but he never actually ended up doing that. And we ended up having to just be able to do this. It was getting close to, like, you'll notice it was 3:30 in the afternoon, and we knew that IR wasn't going to do this, and they basically called us up through the MET team and things like that. And so we ended up just, intervening there. So it saved him an admission and didn't require any, other interventions. And he got put back on his diuretics and all this stuff. Basically, that's the reason why he went back into heart failure. So last but not least, I will show you a case of cardiac arrest. So this was a patient who was found down in the London area in the downtown, and is known IV drug, not known IV drug user, known opiate user, but not an IV drug user. And basically he'd been down for about 60 minutes in the periphery before they actually even got him to hospital. And so as you can see here, T's being done. You can't really see anything on the right-hand side. They're just infusing so many different infusions. But you'll notice here that the patient had a clot. And the clot was actually thrombolized, and this is the second image here. And the clot's being busted up, but 60 minutes of downtime. So one of the things that we're trying to do research on is to see for all these found down patients, unwitnessed arrest and things like that, whether or not clot is a, based on the Reason trial, which was a previous trial done by Gaspari et al., they basically said that cardiac standstill is not 100% predictive of poor outcome. There's like 0.05% of patients that still survive. So again, 99.5% of patients do very poorly, but it wasn't 100%, a censure for poor prognostic outcome. What we want to do in some of the other studies that we're doing is diagnosing intracardiac clot alongside cardiac standstill and arrest, and see whether or not, because the clot itself takes time to form, like 5 to 10 minutes. So it actually builds in that arrest time already. And we want to see whether or not, cardiac arrest with clot is actually a poor prognostic sign, because even thrombolysing that's just going to go everywhere. It might shower, it might cause, ischemic gut, might cause stroke and all those other things. And so maybe we might be able to have a echocardiographic finding that is actually 100% specific for poor prognosis, and be able to maybe stop, resuscitations. Even if we get the pulse back, it doesn't necessarily mean the patient's going to do well, right? So there's things along that kind of stuff in terms of research. We can do, CV ECMO cannulation. So you'll see the SVC here, IVC here, LA and RA, and the wire is going to come down here. And basically we have to make sure that the wire goes into the IVC, and then the cannula can come down later after that. So a lot of different things that you can do with point of care ultrasound. The one thing I would say is that, remember the Dunning-Kruger effect, everybody. So in the early going, everybody thinks, I'm so great. as you do more of this, you'll find out that there's more than meets the eye to kind of learning this stuff. But that being said, learning in this curve is actually really important because it tells you what your limitations are, and getting to the point where you become an expert in something. It takes practice, it takes time, it takes, you know, things, but it's not unachievable, right? Like I said, this is a scalable technology. You can learn as much as you want to, and you'll be able to diagnose some of these things fairly readily on your patients. So I want to end on a positive note, that although like the learning curve for anything, including POCUS, is high anxiety, and when you attend a course like the CRS course, there's a lot of extra information. But over time, as you practice things, you'll be able to go hopefully into this growth curve rather than in stagnancy and fall. And one of the things that we're a little bit sick of in regards to like hearing about is that ultrasound is operator dependent, but everything in medicine is like that, even the history and physical reading, ECGs and things like that. So, you know, if somebody tells you that you shouldn't be doing this, it should just empower you to do more. And I, like one of our colleagues, Brett Nelson, basically said, like, you know, I agree. I stopped repairing lacerations, interpreting EKGs once I found out they were operator dependent. All it takes is more practice. So like you know, people don't tell you to put down your stethoscope or not look at EKGs or not do bronchoscopy surgery. It just takes practice to be able to do it. So POCUS certification forces learning. You can get testamere and diplomat status even within critical care. There's no, you know, a certification that we get to do bronchs, yet we do those anyways. Same thing with laryngoscopy when we intubate. Nobody's certified as that. So it's like POCUS is in a little bit of a weird world because there's so many guidelines and stuff out there, but they're not unachievable. That's what I want to encourage everybody. It's not unachievable. And then, so biggest barriers previously were a lack of ultrasound machines. Where I think the future of point of care ultrasound is that nobody can get to a code or to a sick patient faster than us. We're on the MET teams, we're on the code teams. So actually where I think is if we can do just as good as ultrasound as everybody else, then where our benefit is in the point of care aspect, right? So we have the golden hour in sepsis, we have the golden hour in trauma, we have all these golden hours. So how is it that it's fair to a patient, especially if they're arresting or if they're dying, that they wait till Monday for an echo? Right? Or they wait till, you know, like, you know, until radiology is able to get something. Sometimes being able to diagnose this in the moment is actually really important. And it might save, you know, that autopsy where we don't know what happened, actually being able to put a probe on the chest or probe somewhere, you will figure. So again, after hours on weekends, golden hour. If you are going to do it right. So look up the ASC guidelines, ESC guidelines. If you want to look up TCD, you can look up AIUM. But otherwise, I'll just end there. Sorry, I went a little bit long, guys, but I want to encourage advancement, breaking down that sound barrier. Notice that a lot of the point of care stuff that's done is done after hours, and it has helped patients. It may not have changed their overall outcome, but at least an intervention was tried, as opposed to waiting and letting them arrest and, you know, not figuring out what happened. I want to democratize its use, and I think show you that as a scalable technology, and you can learn as much as you can from it.